Hello everyone, it is September and September is Sepsis Awareness Month. The month is all about letting people know about the symptoms and signs of sepsis and spread awareness. The intent is to encourage everyone to act quickly and get the support that they need. Sepsis is a common and a potentially life-threatening condition triggered by an infection which causes the body's immune response to go into an overdrive. And if not treated promptly, it can lead to multiple organ failure and death. Certain quick facts about sepsis. Did you know that sepsis claims more lives than lung cancer? Did you know that sepsis is the second biggest killer after cardiovascular disease? It is imperative to get ahead of sepsis, know the risk, spot the signs, diagnose early, and act fast. On that note, thank you for joining us on the World Sepsis Day live webinar supported by bioMérieux. It is World Sepsis Day and it is time to talk about sepsis. I'm Dr. Devjani Dey, Medical Affairs Lead bioMérieux South Asia, and it is my pleasure and honor to introduce the moderator for today's webinar, Dr. Chand Vattal. He's the Chairman, Institute of Clinical Microbiology and Immunology, Sir Gangaram Hospital, New Delhi. He's the recipient of several prestigious awards, which include the Hospital Management Asia Award 2002 for Best Hospital Infection Control Program. He's the recipient of the Dharamveer Award for Excellence, the S. Nandi Award for the Best Publication of the Year. He has also received the Long Distinguished Service Award by Shri J.P. Nadda, the Union Health Minister. He has the Best Publication of the Year in Virology, which was published in IJMN. He has also received the IMM Endowment Award 2016. He has held several prestigious positions, which include the immediate past president of IMM New Delhi. He's the editor-in-chief, IJMM. He has been a valued office bearer of IMM DC since 2006 to 2016. He's the chairman of the EQUAS program we all enroll for, and he has more than 35 years of experience in the specialty, 120 publications to his credit, and he has delivered and chaired more than 268 sessions and lectures. I hand over the virtual stage to Dr. Vattal to initiate today's session.
Thank you, Dr. Giuliani.
Yeah.
Can you stop
My
sharing?
pleasure. I will do that. Yes, sir. The stage is all yours.
Yes. While I will share my screen, it is a pleasure to be here with all of you, and I welcome. Is my screen visible?
Yes, visible.
It's a great pleasure actually to be again here on the World Sepsis Day, which has been supported consistently by bioMérieux, and this time a microbiologist friend has introduced. Otherwise, earlier I was alone in introducing it. So very nicely introduced as on today, and she has already told you some of the facts as far as the global burden which we can talk of for sepsis. You know, this is a huge kind of a burden, and every hospital undergoes this kind of, I will call as a treachery when we talk of sepsis. And my colleagues who are here will appreciate it much better. And around, it is say 80,000 people per year die of sepsis, and it's a huge burden all through. So my slides are not moving. I will have to stop share and then do it again. So I hope it moves now. Yes. So global burden of sepsis, if we look at it, is sepsis and related syndromes are most common causes of admission to the ICUs across the world. And in the US, deaths due to sepsis exceeds deaths due to prostate cancer, breast carcinomas, and AIDS combined. So hospital mortality due to sepsis in the last decade of 2005 and 2015, though it has not changed much, and data from 27 high-income countries, you can see that hospital mortality due to sepsis is around 17%, and hospital mortality due to severe sepsis is around 26%. So the global estimate of incidence and mortality due to sepsis is that no population level sepsis incidence from low middle income countries is available. Extrapolating from high income countries, estimates is 31.5 million cases globally due to sepsis, 19.4 million cases globally due to severe sepsis, and death due to sepsis estimated at 11 million deaths annually. It's a huge number. And this is a very commonly used slide. The sepsis facts, where 47 to 50 million sepsis cases per year is reflected, at least 11 million deaths per year, as I said, and 1 in 5 deaths worldwide is associated with sepsis. And the worst is that 40% of cases are children under 5 years of age. And 80% of sepsis cases occur outside of a hospital. So every second counts. We all know that time is very, very important when we are talking of sepsis. And 1 out of every 23 patients in the hospital has sepsis. And 40% ICU, the bill that is the ICU is spent on sepsis. And it is prevalent, it is costly, it's difficult to diagnose, and it is deadly. And the 10th leading cause of death in US. And if you look at this very commonly used slide where you talk of, you diagnose early and you decrease the rate of death or the mortality. So what are we facing? Increasing resistance in gram-necks, and gram-necks particularly in ICUs, non-susceptible organisms like Klebsiella pneumoniae and Acinetobacter and Pseudomonas, non-susceptibility to meropenem in Acinetobacter and Klebsiella, 13% Klebsiella, non-susceptible to carbapenem and colistin. These are a little older figures. It is much more, which we will know from the horse's mouth as we progress. So cons are far more resistant than Staph aureus, which most of us know. Azole susceptibility to bloodstream candida has come down to around 55 to 60%. Multi-drug resistant candida auris has been reported from every corner across the world. It's not otherwise. It was thought that it is only in the LMIC countries, but it has been found to be everywhere. So Indian ICU scenarios for drug-resistant infections, I will skip this slide because we'll see more of this in the subsequent presentations. And the Indian ICU scenario for drug-resistant infections, we already know is relatively very huge. If you look at the gram-negative organisms, predominantly 70%, and now the burden of fungi, particularly the yeast fungi, is there to the tune of 7.5 to 10%. And gram-positive organisms also have started showing up in our ICUs. So Indian ICUs are plagued with gram-negative bugs primarily. To the cardiologist, time is muscle. To the neurologist, time is brain. To the physician caring for septic patients, ladies and gentlemen, time is survival. So has the time come for optimum synergy between clinical microbiologists, ID physicians, critical care physicians, and nursing managers for better clinical outcomes? And I'm very glad that this time we have a nursing manager also on board, which is an addition this time for our webinar on Sepsis Day. So I'm very glad to introduce to you the eminent faculty that we are talking about, Dr. Subhash Todi, who is we should be talking about on adaptation of surviving sepsis guidelines in resource limited settings. Dr. V. Balaji, diagnostic stewardship in balancing risk of sepsis and AMR, advances in sepsis care, revolution in technology by Dr. Nambi, and nurses' role in sepsis management, Colonel Binu Sharma, and we'll have a panel discussion at the end of the presentations. I would like to introduce all the speakers, not that they need any introduction in the country. Dr. Subhash Todi, who is the Director of Critical Care of AMRI Hospitals at Kolkata, is a medical advisor AMRI Group of Hospitals and HOD Department of Academics and Research, AMRI Hospital. He is the reviewer for Critical Care Medicine Journal and IJCCM Journal. I think he is still the editor, unless he has passed on the baton. The ICU protocols, a step-wise approach. He has edited that along with Dr. Rajesh Chawla. And he has more than 50 publications, index journals of national and international repute. Welcome, Dr. Todi. And then we should be hearing from Dr. Balaji V. Raghavan. His current position and affiliations are that he is a professor of clinical microbiology at CMC Vellore, the Hildal Lazarus Core Research Chair, principal investigator of Antimicrobial Resistance Surveillance and Research Network, ICMR. His research interests are laboratory diagnosis of sepsis, detection of AMR and surveillance for the same. Antimicrobial stewardship is close to his heart, and hospital infection control. His other highlights are that publications are more than 70 articles in index journal, and he has been the immediate past editor-in-chief of Indian Journal of Medical Microbiology. We have Dr. Senthur Nambi with us, who is a consultant ID physician at Apollo Hospital, Chennai, a leading ID specialist with 20 years of experience. He has various publications or articles in many reputed national and international journals to his credit. He has been a former secretary of Clinical Infectious Disease Society of India. Welcome, Dr. Nambi. And we also have the Colonel Binu Sharma, who is a senior director, Nursing Max Healthcare Institute Limited. Over 4 decades of experience in nursing services in the armed forces and private sector in clinical and administrative capacity. Her clinical specialization is critical care, cardiothoracic and vascular surgical nursing. 40 years of experience in clinical practice and nursing leadership. So membership associations and awards. She is the president for the Infusion Nurses Society India as with a US affiliate. So founder member association of Nurse Executives India, topmost healthcare leader award from World Health Congress. She has also received Woman of Excellence Award from India Achievers Forum, and also received a Women Achievers Award 2021. Welcome, Colonel Sharma. And I would now request Dr. Todi to go ahead with his thought process. Dr. Todi, please.
Thank you. Thank you, Dr. Vattal. It's always a pleasure to share a platform with you in different webinars. So let me share my screen. Can you see my screen?
Yes,
Yes,
you
sir.
can put the slideshow, yeah.
Okay. So thank you and welcome again. Thanks, Dr. Vattal, for setting this stage. There are a couple of things before I start. Infection is not equal to sepsis. Sepsis is an host response to an infection. So I'm going to highlight more on the host response side than the infection side, which will be covered by the other speakers. The second is the word resource limited. The resource limited is not synonymous to low or middle income. We can have high resource settings even in low middle income, and in high income countries can have a low resource setting. So that should also be kept in mind. So what are resources? When we talk about resources, we talk about human resource, doctors, nurse, paramedics. We talk about drugs, we talk about different monitors, and we talk about different diagnostic capabilities. So these are the resources. And as we go around, let us see whether we can utilize, whether we really have very low resource in all of them, or is it possible to get around with the resources that we have and still follow the Surviving Sepsis campaign guideline? These are the main guidelines that have been coming in vogue from 2021, and it's very important that we follow this while managing our septic patients. So the first and foremost thing in the guideline is this recommendation that we should use a performance improvement program for sepsis. That means we should screen acutely ill patient in the hospital for sepsis, and we should have a standard operating procedure. Over the last year or so, we have been maintaining a sepsis registry in India, and these are the questions that have been asked to all the institutes who register. Does the institute have screening for sepsis in high-risk adult patients? Does the institute have a written SOP for initial resuscitation of septic patient? Does the institute have a sepsis team? And does the institute have performance improvement program and periodic audit on sepsis? We have around 30 to 35 big hospitals all over India, different parts of India. But I must say, we haven't have a yes to most of these questions in most of the hospitals. So the question is, does it really require a lot of resources to have these things? Human resources are required, but then even in the big hospitals, I think it is possible to do it. Now, let's go through it. What does this all entail? Sepsis Performance Improvement Program. We need to screen for sepsis in all acutely ill patients who have been admitted in the high dependency unit, ICU, and also acute in the emergency department. We need to educate our staff, the doctors, the junior docs, the nurses. We should measure the different sepsis bundle. How are we performing, and what is the patient outcome of our sepsis patient? So let's start with sepsis screening. What does it entail? There are a lot of scoring systems, SIRS, NEWS, MUSE, SOFA, QSOFA. We can pick up any one of them. As you can see, the SIRS is temperature, heart rate, respiratory rate. So this is doable. This is doable even in the least resource setting. The question is, are we screening this for all our acutely ill patients, and are we documenting how many patients of SIRS are being admitted in our ICUs and in our wards? The QSOFA. You see, the QSOFA is even easier. It has a respiratory rate of 22, altered mental status, and systolic pressure. Even a junior nurse would be able to do it. One thing to note in this is the respiratory rate of 22. You might wonder from where this 22 has come. There is not much of science behind it. The reason the number 22 was put in, because respiratory rate is usually put down as 20 as a default by most of the healthcare workers, because nobody counts a respiratory rate. So the reason of putting 22 is to make it aware that whoever is counting the respiratory rate counts it, because for 22, you just can't put it like 22, you have to count the respiratory rate. So it's very important that even simple nursing maneuvers are so important in order to identify and screen patients for sepsis. Just give an example of MUSE. Again, the parameters which are required is doable in almost all settings. So the first thing that we can conclude is it is easy to screen for patients with sepsis and document it. So I think it is possible. We can at least follow this part of the Surviving Sepsis. The Surviving Sepsis campaign guideline says it can be done manually, and having an EHR makes things easier, we all agree. But if you don't have an EHR, even a manual recording should suffice. So I think having a screening methodology and documenting and then doing a performance improvement is very important. Then coming to the sepsis bundle. I will just go through these bundles and see how can these be adapted in our setting. You see, the first is measure lactate and remeasure lactate if initial lactate is elevated. Now there comes the problem. Many of the resource limited settings do not have lactate facility. Many of the ABG machines have lactate in big hospitals, but in resource limited setting, you might not have facility for lactate. So what's the alternative? For adults with septic shock, we suggest using capillary refill time, which can be done everywhere, even in the least resource setting. Question is it equivalent to lactate? This is how it is done. It has to be done in a standardized way, and one has to calculate the time of capillary refill. Usually it is less than 4 seconds. It's not only equivalent. In a study, a biggest study, Andromeda shock study, had shown, if anything, it is slightly better than lactate to know whether the patient is getting perfused and whether he is still at risk of organ perfusion. Though the mortality was not significant in this study, they are equivalent, but organ function, the SOFA score, was less in the peripheral perfusion group than in the lactate group. So you see, we don't require lactate, but we require a very diligent bedside clinical monitoring, and with capillary refill time being documented in the notes, and that can be followed. That can be followed on an hourly basis if needed. It is cheap, doesn't cost anything, but requires dedication. In fact, in this sepsis registry that we have mentioned, we have around 1,000 patients now. This is an unpublished data. We did a multivariate analysis, and we found clinical features of hypoperfusion had the highest odd of mortality than any other features. So you see, there is definitely a thing into it that doing a capillary refill time is very, very important. It can replace lactate even in the least resource setting. So we can definitely adapt surviving sepsis so far as lactate is concerned. Second is obtain blood culture before administering antibiotics. Dr. Vattal will be knowing it the best, but blood culture bottles are not immediately available in many of the low resource settings, but they can come from the microbiology, from the pathology, might take time. So one can wait till 45 minutes. You might wonder why 45 minutes. You should not wait more than 45 minutes to give antibiotic if the blood culture bottles are not there. The reason is it takes around 15 minutes to half an hour to infuse the antibiotic. And initially in the 1 hour bundle one should get an antibiotic within an hour. So if you wait 1 hour to get the blood culture bottle and then start antibiotic, it will be 1 hour and 1.5 hours. So that's why they have put it as 45 minutes. So if you don't have access to blood culture bottle, you can start antibiotics after 15 minutes. Now the situation in the latest update of the guideline, I think people were giving antibiotics broad spectrum within an hour in both patient with shock and without shock. Most of the studies of early appropriate antibiotic saving life are in patient with shock. So now it's time that one needs to ponder, one needs to wait and see whether we can have some kind of an idea what kind of an infection it could be. If we have some idea what kind of an organism it could be, then only give a targeted antibiotic or at least lower spectrum antibiotics, especially in a patient without shock. So in a patient without shock, and if we are not 100% sure that this is sepsis, one should wait and try to investigate the patient. And I think this should be adopted in every setting. So rapid diagnostics, that is where I think we can narrow down our broad spectrum antibiotics. One third of, there are a lot of non-infectious causes, a lot of viral infections. And that is where I think, like in COVID time, even in the least resource settings, we're doing COVID tests. So I think over time, even in the lower resource setting, because at the end of the day, it will save more money for the lower resource setting if we invest at least in some important viral diagnostics so that we can decrease our antibiotic use. So though it looks like at the present moment, rapid diagnostics is not in the armamentarium of a lower resource setting, but I think over time this has to come. So there have been recommendations for infection management in patients with resource limited setting, choice of empiric therapy, timing, taking blood cultures, source control. One should not use combination, using some biomarkers, but I think it is rapid diagnostics will be the most important thing. And hopefully over time, there will be more access to this. Then coming to the fluids, we have to give fluids. For patients with sepsis-induced hypoperfusion, the guideline says 30 cc per kg of crystalloid to be given to be started immediately, but has to be given over 3 hours. Now, in a resource limited setting, and especially in areas where patients come late, and many of the patients are anemic, they are hypoproteinemic, whether this kind of an approach, is it useful? Because most of this data of 30 cc per kg comes from a very high income country, in a high resource country. So in a resource limited settings, you see, this was done in children in Africa, and they found that giving boluses of albumin and saline kills more children than giving no bolus. So that was not useful. This policy was not useful in cases of African children. Another study done in Zambia also showed that if you follow the 30 cc per kg, the survival is less. So there is something that we need to look into. Probably we should not be following exactly. So even in the newer iteration of surviving sepsis, which will be coming next year, probably the wordings would be changed, and they would like to start with a lower dose, say 10 cc per kg, watch the patient carefully, and then keep on giving aliquots of 10 cc. So it looks like that we have to individualize our fluid. And so the other thing about the fluid resuscitation is using dynamic measures, not static measures. So the dynamic measures to know whether the patient requires fluid or not, echo is again a very important tool. And this is again just like rapid diagnostics. Having an ultrasound or an echo machine is becoming very important. And I think if one has to invest on something even in the lower resource setting, will be a cheap small echo machine or an ultrasound machine, which will be very helpful for initial resuscitation of septic patients. Lastly, applying vasopressors to these patients. For adults with septic shock on vasopressors, it is a septic shock on, they recommend to have a MAP of around 65. Now, the question of vasopressors like noradrenaline, people are reluctant to give noradrenaline in low resource setting because they think it requires a central line. But there are many studies now which says that it is safe to administer noradrenaline through a peripheral channel, so long it is very closely observed in order to avoid extravasation. So it looks like everything is possible. Even in the least resource setting, we can do capillary refill time. We can screen patients for sepsis. We need to document it. We need to follow the patient to see what is their outcome. We need to to see whether what is our performance measure? Are we measuring capillary refill? Are we sending blood cultures? Are we giving antibiotic at the right time? Are we giving fluids in aliquots? Are we applying vasopressors? This can all be measured and documented and can be audited. So I think even in the least resource setting, it is possible to adapt the sepsis bundle. I think it is the mindset and the dedication which is very, very important. So I will end here and hand it over to Dr. Bhattal.
Thank you, Dr. Todi. As usual, it is a treat to listen to you. We will come back to you when we are in the panel discussion, and you have very beautifully tried to tell us that please don't hide behind the low income, blah, blah, and that kind of activity. So we'll come back to your topic, sir. And in the meantime, now I would request Dr. Balaji to start with his thought process as to what does he think as far as diagnostic stewardship is concerned in balancing risk of sepsis and antimicrobial resistance. Dr. Balaji, please.
Thank you, sir. I'm just waiting for my slides to be displayed. So I'm requesting.
Yes, slides are visible. You can put it on the
Sure, sir.
slideshow.
Okay. So for the next few minutes, I'll be talking about the diagnostic stewardship, balancing the peril of sepsis and antimicrobial resistance. So the 4-5 points which I would like to highlight is, one is diagnostic stewardship, blood culture, how good to carry out the blood culture collection. Second one is molecular rapid diagnostic testing. Third is rapid phenotypic antimicrobial susceptibility testing. Then what are all the discrepancies which can arise when you do genotypic first and phenotypic later? Phenotypic is the gold standard, but sometimes for an earlier result, we need to go for a molecular rapid diagnosis. In that situation, what kind of problem it will give? And last, I would like to share certain information about the susceptibility testing, proper susceptibility testing of Asciona mavibactam. So blood culture. So a few minutes back, Dr. Todi has very clearly mentioned that how the sepsis bundle recommends to give antibiotic. So in the initial the surviving sepsis guideline in 2016, they said that after collecting the blood culture, so within 1 hour, you should give the antibiotic. But this was not endorsed by Infectious Disease Society of America for the simple reason, when you give antibiotic within 1 hour of patient getting into the emergency, more than 40% of the individual doesn't require antibiotic because they are non-infectious conditions. So, and there was a lack of to distinguish between suspected sepsis and septic shock. That was the reason. So the Critical Care Society and the European Society of Intensive Care Medicine, when they proposed this with antibiotic within 1 hour, this was refused by IDSA. Subsequently, in 2021, in the sepsis guideline, the IDSA accepted to give antibiotic within 3 hours if it is possible sepsis without shock. Whereas within 1 hour, if it is a frank sepsis shock or high likelihood of sepsis. So this is the two distinction. If it is a frank sepsis shock or highly likelihood, then you can give. Otherwise, hold on for 3 hours. Just reevaluate, or if possible, you can do some point of care testing and then take a call on the giving antibiotic. Because here in this aspect, two things comes into a highlight. One is the diagnostic stewardship. Another one is antimicrobial stewardship. So it's very important that within 3 hours, if you can generate some evidence, then you can initiate appropriate therapy. So there are many number of tools now, approaches are being evaluated where within 3 hours, you can try to get an infection or non-infection. If it is infection, what kind of organism is growing in the blood or circulating in the blood. So now instead of the standard gold standard blood culture, they are trying to identify the floating organism or circulating organism in the blood, directly correcting the blood and subjecting that to the molecular rapid diagnosis. So I'll be talking about both the platforms, the conventional gold standard blood culture as well as the molecular platforms. The limitation of the blood culture. Blood culture is an imperfect tool for a deadly condition. So really everywhere you won't get a good result from the blood culture, unfortunately. Two reasons are very important, though I have listed other things. I will highlight on two things. One is that 30 to 50% of the positive blood culture are contaminated in most of the places. Not in all the places, in certain places up to 50% contamination is seen. Second is false negative blood culture occurs 40 to 60% of cases with suspected sepsis. Again, the numbers are too big. And what are the reasons for 60% of the false negative blood culture? Prior antibiotic therapy, in many times you cannot avoid, so you can excuse this. Second one is more important, which I would like to highlight, is inadequate volume of blood collection. So I'll be talking little more on this inadequate volume of blood collection. And of course, the other two are being a fastidious non-cultivable organism. And the last one, lack of sensitivity due to low organism load. So now I'll go on to the inadequate volume of blood collection. See, how many blood culture you need to do? You all know that minimum two sets has to be done. If you are collecting single blood culture set, then what happens is you miss 10 to 40% bacteremia. So not only the bacteremia you miss, and also it will become challenging to distinguish blood culture contamination from true bacteremia. And third is 40% of the blood culture drawn in the hospital are single blood cultures. So this is one huge gap where we have to improve or make sure that set of blood culture is done. Second one is, what is the current recommendation? Of course, 2 sets, but typically consisting of 10 ml of blood in each aerobic and anaerobic bottle. Minimum 10 ml needs to be added. But what we are seeing is 40 to 85% of the blood culture contains inadequate volume. Almost up to 85% it's inadequate volume. The 10% we are not giving. Repeated blood culture, is it required? Actually, in many circumstances, it's not required, and many people continue to do repeat blood cultures. That is another area which we need to be mindful. Okay, now I move to the blood volume again. A small difference can make a big impact. How? Look at the sensitivity and specificity. If any blood culture corporates comes with an automated system and commercial blood culture broth bottle, usually they calibrate to have a good sensitivity, specificity of yield based on fixed blood collection volume or from the patient inoculum. So here in most of the blood culture system, the bottles are calibrated to give highest sensitivity specificity for 10 ml of the blood. You need to read at the literature what is the ideal amount of blood need to be inoculated in pediatric bottle or in adult bottle. So that's very, very critical. What it is calibrated and what is recommended, that much of blood needs to be inoculated. So look at the statistics, not only in a particular country, across the continents, what they have seen is 20 to 97% of the blood culture submitted contains less than 8 ml. When it's expected to have 10 ml, it's less than 8 ml. And on average, it's between 2 and 5 ml only. So it's not even half. So when you cut down by 50% of the inoculum, then your sensitivity specificity also gets compromised to that many number of percentage. That is nearly 50%. Look at this another table, new study, which shows that for the total number of culture and total number of true positives, the percentage of true positives definitely increases with the average blood culture fill volume. If you would have filled for 10 ml above 7.2 ml, then there is a significant increase in the true positives. So it's more important. Again, I would like to emphasize that you need to collect minimum 10 ml per bottle. So then only the yield will be much better. So this is totally in our control and we need to do this one. So now I move on to the rapid molecular diagnostic testing. So now the FDA approved panels are there for BCID2 upgraded version, where you will have all the common gram-negative bacteria except Burkholderia pseudomallei, and gram-positive almost covering all the most common, and yeast. So almost 95% of the common organism which we come across in the sepsis are covered in this panel. In addition, it covers the CTXM and carbapenemase, and for gram-positive MEC-A, MEC-C, and for cholesterol resistance. So this helps a lot in a short time of period to identify that. And now we do have pneumonia panel also, where the pneumonia panel contains the semi-quantitative log bins. This is a semi-quantitative log bins for all the common bacterial organisms, whereas non-quantitative, that is qualitative for atypical bacteria like chlamydia, legionella, and mycoplasma. Also, all the viruses, most common viruses, and the most common resistant genes for gram-positive and gram-negative are covered in the respiratory panel. The best part of the respiratory panel is its quantitates, and the IDSA defined cutoff value to differentiate colonizer from pathogen is less than 10 to the power of 3.5 colonies are colonizers. Above that are pathogens. And even if it is above, multiple microbials are there based on the high numbers. And if it is a pathogenic organism, you can give weightage to the highest copy number having organism to be treated than lesser number. So it really helps to identify. It's evolving. People are catching up with this. So over time, I hope this becomes a standard of care. And you can see as of now, it has gotten a good positive predictive and negative predictive value for both the bronchoalveolar lavage and the sputum specimens. It's almost about 95%, both sensitivity and specificity. And this is really one of the most useful meningitis encephalitis panel, where 14 targets are identified within 1 hour. So it contains all the bacteria, virus, and fungi which are more common. So it always helps, because now sepsis in isolation we should not see. Sepsis could be secondary due to meningitis or respiratory pneumonia. So the best way in children, pneumonia samples are very difficult to get. Only sepsis blood culture is easy. Again, for meningitis, blood culture will be the easiest. But when you have CSF panel, then it will be very useful. Next slide. Okay, this is another interesting new development in the rapid molecular test. Here, I would like you to show you that this is BioFire Spotfire. This is called not BioFire, Spotfire. 15 targets. The turnaround time is within 15 minutes. So your deadline for giving antibiotic is within 3 hours. Whereas here, within 15 minutes, you can rule out bacterial and viral respiratory infections. Again, for antimicrobial stewardship as well as diagnostic stewardship, it will be an added new platform. Now, I will talk about the genotypic phenotypic resistant discrepancy. So what the CLSI says is, one second. What CLSI says is, here you can see that if it is MRSA and if you are detected MEC-A, if the gene is present, then approximate accuracy is almost 100%. If the gene is absent, then it is MSSA and the accuracy is 100%. Similarly, for Enterococcus, if VAN A, VAN B is there, presence, the accuracy is 100%. And if it is absent, again, the accuracy is 100%. For gram-positive, absolutely there is no issue. When it comes to gram-negative, please be little attentive. For CTXM, ESBLs, if the gene is present, the accuracy is almost 100%. But if the gene is absent, then you should not think that it is susceptible. So it will be only 50 to 95%, it will be reliable or accuracy is there. So you need to cover even with the carbapenem. That was that little trick here. So you need to be a little aware of this. If it is for carbapenemase, again, it is between 10 to 98%. See the range 10 to 98. How this happens? I will give you one example. Sorry. Okay. See here, the best example I can show you is carbapenemase versus non-carbapenemase producing Pseudomonas aeruginosa. You all know that Pseudomonas aeruginosa resistant is more common due to OPRD loss, followed by hyperreflux. These two are non-carbapenemase producing Pseudomonas aeruginosa resistant to carbapenem. Here, it can be due to metallobeta-lactamase, that is carbapenemase producing NDM. Unfortunately, almost 100% of Pseudomonas aeruginosa has got Pseudomonas derived cephalosporinase. So that's the reason up to third generation cephalosporin, up to second generation cephalosporin, it is inherently resistant. We depend only on two cephalosporins, that is ceftazidime and cefepime. No other cephalosporin is useful here. And ESBLs are very rare. That's why we are not depending much on the beta-lactamase inhibitor for Pseudomonas aeruginosa. In this case, if you depend too much on the gene target, and if it is due to OPRD or hyperreflux or PDC or combination of these three, then your result will be the reliability very less. That's the reason they are saying that molecular rapid diagnostic followed by phenotypic, if you follow the molecular rapid test, is between 10 to 98%. I hope you have understood this. Okay. Now, in this situation, how will you overcome? So the best way to overcome is, once the genotypic is done, the next best thing to happen is use the specific reveal rapid AST system. This is a phenotypic system where you can overcome the problem. It's not moving. Okay. So this is recently approved by FDA 1 year back. All you need to do is, once the blood culture is positive, take the supernatant from that bottle and inoculate into pluronic water, and then the diluted with the pluronic water is added into the AST panel and load it into the machine. Within 3 minutes, this process can be completed, and within 6 hours, you will get the susceptibility report. And the susceptibility report, it will be like this. You can give exact MIC values 0.5, 1, 2, 4, 8, 16 with the negative and positive control. And this will be the best thing to happen within 5 hours of blood culture positivity. So you don't need to wait for the conventional subculturing onto the blood agar plate and identifying, or do the broth microdilution. This is a new system approved by FDA. This will help you. So this is how it happens. What it happens is, patient admitted, within 24 hours, first day or second day, you will get the blood culture positive. Usually in the second, early part of the second day, you will be having positive blood culture. Do by MALDI-TOF ID. Then within 5 hours from there, you have the AST phenotypic system within 2 days. Otherwise, conventionally, what happens is, you will have the blood culture positivity within the same day. But if you don't have the MALDI-TOF, then you need to subculture, wait for the next day for the organism to be identified, then set up AST, then it takes 4 days. So these days, with highlighting on
They're running out of time.
Sure, sir. Last slide I will come.
Yeah, I know. Thank you.
So I would like to say that there is a problem with the ceftazidime avibactam disc diffusion. It's very well known that up to 12% for Pseudomonas aeruginosa, it can give major error and very major error. And the best way to go about determining the Osteonum avibactam susceptibility is, instead of doing ceftazidime avibactam and Osteonum synergy testing, it will be good to do simply avibactam Osteonum MIC. All you need to do is, with a different dilution of Osteonum, keep the avibactam 4 microgram in constant, and usually the reading breakpoint is 4 milligram per liter. But once this two combination gets approved in the FDA, the Pfizer may ask them to designate breakpoint into 16. Even if they are not given, definitely they may be awarded with 8 based on the probability of target attainment. So safely, even 8, you can give us susceptible and you can go ahead and treat the individual. So that's what I want to say. But in India, the major problem is with the E. coli, which has got NDM plus PB3 insert plus AMPC, that is CMY42 confers resistant to aztreonam-avibacter. So you need to be a little careful because this is the common which we encounter now. And the other two systems, which is not good, disk stacking method and e-test disk method should be avoided. And the last component is what are the best molecular tests available to overcome the blood culture, NAT and NGS. The problem with this two system is, the good thing about this two system is even if they had antibiotics 2 weeks earlier, still you can pick up the positives. And the incremental increase is up to 50% in NGS or a NAT compared to 20% conventional BC, 30% improvement, incremental increase of positivity will be there. But unfortunately, even asymptomatic individuals may have 30% positivity because it's a DNA. The dead DNA also may give false positive. The last slide is not necessarily only the blood, the whole blood you can use to get the identification of the organism. Even the plasma, from the plasma, cell-free DNA can be used. At present, the problem is the true infection ranges from 20 to 450,000 molecules per microliter of plasma. But the normal is 300, and this will be elevated in the sepsis. So we need to have a cutoff value for every organism. Then we can easily do this. This colony cell-free DNA can be detected within 3 hours. So that's the beauty of that. So with that, I will end my talk. Thank you very much.
Thank you, Dr. Balaji. It's always wonderful to listen to you with the huge amount of information that you try and give us in a capsule form. So thanks a lot for that.
Thank you, sir. Thank you, sir.
I would request our Dr. Nambi to go ahead with his presentation, and he's going to tell us about the advances in sepsis care, revolution in technology. So he may take it further forward in another direction for clinical microbiology. Dr. Nambi, please.
Yeah. Good evening. Are you able to see my screen?
Yeah, very clearly.
Yeah, fine. Thank you. And thanks for having me here. Thanks, Dr. Chal. Thanks, Biomary and AMM for having me here. And I think with respect to basic sciences, pathology was hogging the limelight for a number of years. And come to microbes, come to antimicrobial resistance. In this day and age, if you are practicing ICU medicine or practicing infectious disease physician, I don't think we can even function without a good microbiology and a microbiologist lab that we have. As far as a clinician is concerned, when you have a patient with fever, you're looking at whether it is an infection or non-infection. Then you have to choose the right drug at the right dose and the right time. And of course, for the laboratory, the clinician has to give the right sample at the right time. And the interaction between the clinician and the laboratory personnel is very crucial in respect to outcomes or appropriate choice of antibiotics. And with respect to two sample sources, which gives you information which can be equated to gold in clinical practice. One is blood culture.
Hello. Hello. Have we lost the?
Yes.
Looks like it.
Yeah.
Mm.
Do you want us
Looks
to log?
We are just connecting with him.
We are just connecting with him. We'll be right back.
Can we ask the audience to write something in the chat? I don't see any questions still.
There's hardly anything here.
So whoever is listening to this discussion, please do send us some questions.
Because we cannot see the number of participants because they are on the different
different link.
faculty link, so that will be on the
We have more than 1,000 participants live, and we would request them to please drop their questions on the chat box, please. We'll highly appreciate that.
But their chat box will be different from ours, no?
Yes.
So we can't see their chat box. So how are we going to see their questions?
Only organizers will be able to pull out the questions.
So then you have to copy paste to our chat box. So are you seeing it in their
We
chat
do
box?
that. We'll let you know, sir, shortly.
That, yeah.
Thank you, ma'am.
Where has Santhur gone?
Are you able to get him on the phone?
Yeah, it's trying to, but he's not picking up.
Oh,
He's not picking up.
that's interesting. So can we take Dr.
Yes, yeah, I think I will do that. I would request in the meantime, till he is back with us, Colonel Sharma, to go ahead with the nursing role in sepsis management.
Sure,
And-
sure.
Yes, and
Allow me a few seconds.
But I
yes,
think he's back now. Senthur is back.
Santhur, oh yeah, he's here.
Yeah.
Okay, we are trying to delegate your time to Madam. So Santhur, please go ahead. If you are through with their slides. Can you catch up with the where you left?
I'm not sure which slide I
First
lost
slide.
connectivity.
First slide.
Doesn't matter,
First
doesn't
slide.
matter. Wherever you think.
Because I had,
It's after 2 or 3 slides, Senthur. You had covered.
okay,
First,
this one.
No, we
We
can't
can't
see
see the
your slide.
slide. Share
You have to
the
share.
screen.
Just a minute. Can you see it now?
Yes,
Yeah, yeah.
right.
That's
Yeah.
the point.
Was it?
Yeah.
Was it with this slide?
Yeah. This slide you have.
Go
Yeah.
ahead, go ahead.
I'm sorry. I didn't even realize that I had lost connectivity.
Oh. We lost him again.
Some problem with his connection.
Yeah.
So I think Dr. Vattal, can we let's get Dr. Colonel Sharma while he changes his connection to a different one, I think.
I think I will upload my slides.
Yes. I will request Dr. Dayani to kindly inform him. In the meantime, we'll go ahead with Colonel Sharma and go back to
Sure.
him once his
Sure,
connection is stable.
Sure.
So, Colonel Sharma, kindly go ahead because people must be
Sure.
getting restive. Yes, madam, please go ahead. It's good to hear your perspective because we have not been having nurses' perspective in
So,
sepsis.
Thank
Whenever
you.
we
Thank
get
you.
something like that.
Thank you, Dr.
I'm very
Vattal.
keen to
First
listen
of
to you.
all, thank you
Please go
for
ahead.
having me along with the expert clinicians. And as you said, this is the first ever time nursing is presenting such a crucial role. We heard from the previous speakers how important is to have nurses doing those very, very basic activities. With that note, I thank the organizers and I thank all of you. So let's hear what nurses have to do. We saw all these stats in Dr. Vattal's presentation, the opening presentation. So imagine the amount of patients die each year as per CDC in US itself, which is an advanced country. Out of 1.7 million cases, 2.7 lakhs die, which is nearly 15%. Also, the global burden of study, it's an old study, 2017, estimated 19.7 million cases. Even in developing countries, we see very high alarming stats. 60 to 80% childhood lives are lost because of sepsis. And also we see the money spent in the US hospitals, 23 billion, which is a very high cost. What is also stated in multiple studies, when patients get sepsis, they keep coming back to hospitals for continued illnesses. Hence, the healthcare spend and the utilization of hospitals because of sepsis is always high. So these are very, very alarming stats on sepsis. This is evolution of the definition. It is important for nurses to understand that these basic signs and symptoms, what you see, you can actually alert the system on defining sepsis, whether it is rigor, there is a raised fever, or there is hypothermia, or there's tachypnea, or there's respiratory alkalosis when they do ABGs, or there is edema in a patient, or there is altered WBC count, whether it is below 4,000 or about 12,000, whether these are hemodynamic alterations like arterial hypotension, tachycardia, increased cardiac output, altered skin perfusions, also the sign of organ dysfunctions, hypoxemia, altered sensorium, hyperglycemia. All of these signs and symptoms are easily understood by the nurses if they're trained well on recognizing sepsis. Although these are very, very basic vital assessments for a nurse, especially in the critical care setting. Moving on to the adult criteria on SIRS and sepsis and moving to shock. In this, if we see the raised temperature or hypothermia, heart rate more than 90, in the ER, when patients are received by nurses, they carry out the triaging of the patient. They are the first responders and they do the triaging in most of the hospitals. So if they are aligned well on how to recognize the early signs of sepsis, even though when patient is not in shock, it will add a lot of value in early recognition, early diagnosis, and very early management. Respiration, we saw that more than 22 as per QSOFA scores. WBC count, whether it is raised or low, when the bloods are sent and results come, the critical values can be easily recognized by nurses, and critical escalation on lab test can be done by the nurses. In terms of shock, usually sepsis with either of these one or two of these parameters, whether it is hypotension, whether it is renal, where there is reduced urinary output, or respiratory, or altered sensorium, all of this is recognizable by the nursing team. So if there are a lot of nurses in the webinar, I will really urge them to go through the SOP, which was mentioned by one of the speakers, that the hospital must have a SOP on sepsis management. All of these parameters, they need to understand from the SOP that what is the importance of taking vital parameters. Nurses take vital parameters all the time. That is the highest number of activities they do in a shift. In 8 hours, if they have 6 patients assigned to them in a ward, they would do at least 2 or 3 times the vital parameters for all of these patients. Is there a changing vital stats for the patient? If they can understand that and they can escalate on time, it will add a lot of value to the entire clinical management of the patient. We heard from the previous speaker, I think Dr. Subhash Todi, on surviving sepsis campaign. He explained it so well. What are the newer guidelines on the surviving sepsis campaign? Although it gives extensive guidelines on a medical management, I went through the entire document. It is silent on nursing care or nursing contribution in terms of the sepsis management. But what I must state that expert nursing knowledge, skills, competency building, and continued training will add a lot of value in managing sepsis patients and their ongoing change of status, if they are deteriorating or if they are improving, if they need to move from a ward level to the high dependency unit level, or if they have to move from a HDU to a ICU when they're going into shock, is very, very important where nursing can contribute. So I've just summarized in this slide where all the nurses' role come in sepsis management. Definitely when they receive patients in early recognition, each of these points I've explained in subsequent slides. In terms of screening, whether we are using SIRS or we are using QSOFA score, Blood culture, nurses play the most crucial role in collection of blood culture, in prepping the skin, in collecting, in labeling, in transporting, and also when to collect, the timing of blood culture. In terms of intravenous resuscitation, when a patient is in shock, again, nurses play a crucial role in managing a proper IV line or getting the clinicians to have a central line or an arterial line as required for the clinical setting. Administration of the antibiotics or antimicrobial therapy, oxygen management, oxygen therapy, completely managed by nurses under supervision, unless they understand the importance. If patient is desaturating, saturation is falling, or there is or how to give oxygen, whether it is bag mask or high flow oxygen therapy, all of this has to be managed by the nurses very seriously. Continued monitoring and assessment of the patient in sepsis, even when patient is not in shock. Administration of vasopressors. We heard from the previous speaker on what to choose, whether it is norepinephrine or in later stage, whether dobutamine has to be added. Monitoring the patient and titrating the dosage as per the changing condition of the patient again falls into a crucial role of the nurses. And of course, collaborative care, because managing sepsis is not just one team approach. Doctors, nurses, the pathology department, all of them have to work together to manage a patient to get better. Few more things on nursing. So in terms of early recognition, thorough assessment of clinical symptoms and mental status when nurses receive a patient or when they assess and reassess a patient, it is important for them to have a proper monitoring and a documentation of all of these clinical signs and symptoms, including the GCS scoring. Clinical judgment. Sometimes nurses, not sometimes, apologies, all the time nurses spend time at the patient's bedside. They're there 24/7 in the ICU, in the HDU. So subtle signs of patient condition changes, and also depending upon the history and current clinical status, nurses will be able to alert the clinicians if there was a spike, if there was an altered sensorium, so the mental status was changing, or if there was skin changes, skin perfusion changes, if there were changes in the respiratory parameters, patient had tachycardia, was there a fall in blood pressure, the systolic BP, all of this can be very stringently monitored by nurses and also reported by them to the treating clinicians. Effective communication, this is where it comes to nurses sometimes have all the readings and the monitoring documented, but it is not communicated and escalated at the right time for very early intervention by the clinicians. And also when reports come, nurses should be able to recognize the abnormal values. If they get a blood culture report, they should be the first one to inform the clinician. A lactate report or a WBC report, all of this is well taught to them. They should be able to do the communication and documentation well in time and very effectively. And again, observing the signs of deterioration when patient's condition is worsening. For example, a patient is admitted to the HDU and patient is still not in shock, but nurses should be able to recognize if the condition is going bad, if vital signs are changing, if there is an organ dysfunctional, or if there are changes in the mental status of the patient. They are the ones who should raise an alarm, a RRT, and get the team to evaluate and get the patient across to the ICU without loss of life, well in time. This is on QSOFA and search score. So here I've just put in the basic criteria for nursing understanding, training and competency mapping of every single nurse. Nowadays, there's a problem of attrition. Fresh graduate nurses, they find the place even in the HDU and ICUs. Many private hospitals struggle with very high attrition. Hence, one-time training and competency mapping is not good enough for the nursing department or for the nurses. They have to be trained over and over again. Their competency score, whether they are at a novice level, at a competent level to understand the sepsis condition, or at an expert level where they can coach and mentor the junior nurses to understand the assessment of the patient very fast, initial screening of the patient, whether in ICU or in the triage, reassessment from time to time, documentation and communication has to be diligently done by the nursing team and adds a lot of values. We heard so much about blood culture. I would say for all adult patients, blood cultures are collected by the nurses. Sometimes for pediatric group, pediatricians do collect the cultures, but nurses collection method, the strategy of collecting, when to collect. I would just set an example here. When doctors write orders, blood culture and sometimes empirical antibiotics are all written in one order in the EHR or manually. Nurses must know that cultures have to be collected first, then only they have to give the shot of antibiotic. So patient assessment, verification of the orders on blood culture, the paired culture, sets of cultures. We heard that what is the accuracy when you collect adequate amount of blood culture and a set of culture. The collection methods, skin preparation, time of collection, sending it across on time to the laboratory. Sometimes you've taken, you are trying to manage the patient if patient is in shock, but the culture is still lying in the ICU or the HDU hasn't gone to the lab. How are we going to get the reports and how is the patient going to get a specific set of antimicrobial therapy? So all of this needs to be managed by the nursing team. They should be well educated at the time of onboarding in a hospital on how to collect blood culture. Bottles have to be available in all critical care areas because this is one of the things which is critically required for all the patients, and they must know how much volume to collect. And this is what I wanted to showcase. If you have just single set of culture, what is the yield of pathogen recovery? With two set of cultures, it is nearly 90%. And with three set of cultures, it is more than 98%. Hence, adequate volume and culture sets is the key understanding again by the nursing team. Even if it is at times missed out by the ordering physician, the nurses should reach out and take that call and communicate. For pediatric, I just wanted to put in a special slide for the pediatric, the blood culture volume for pediatric patients. We heard from the previous speaker that the volume collected in the blood culture bottle is so inadequate. At times it is 2 ml, 3 ml, and for pediatric at times you just find 0.2 ml or 0.3 ml. We get the cultures rejected by the lab for inadequate quantity, or when the report comes, it is contaminated culture. We saw nearly 40 to 50% cultures are contaminated. We need to take all the measures. The nursing leaders need to have a proper SOP on blood culture collection and management. It will add a lot of value where you will not have rejection of samples. Intravenous fluid resuscitation, again, nurses play a very important role here. Starting with assessment, once there is early recognition of the condition, the intravenous line placement, a proper line where you will need to give the IV fluids if the patient is in shock. Fluid administration should be monitored very strictly. Once you've started the fluid, the rate of fluid monitoring through your syringe pump or the regular sets, also a strict monitoring for the pediatric group, where the fluid is going at the right speed. It is not running faster than required, and it is not a delay that a bottle is going for 6 or 8 hours. These are all completely nursing responsibility and assessing the patient for any adverse effects. Administration of antibiotics or antimicrobial. Here, nurses play again a crucial role. Nurses need to really remember that at times in today's setting, all antibiotics are not made available in all the ICU or the HDUs. Hence, they need to act faster once the orders are there. They need to procure the antibiotics soon after the blood culture. If the antibiotic has to be administered within that window period of 1 hour when a patient is in shock, nurses need to give it complete importance. For them, it is not another one-off antibiotic dose. It means saving a patient's life. And we have seen some stats that if antibiotics are delayed, every hour costs additional 8% death because of septic shock. Hence, accuracy of antibiotics, proper dosing, proper infusion, monitoring for adverse effect, and documenting the same. Oxygen therapy, again, one of the very, very crucial role of a nurse, assessing a patient's respiratory status, recognition of hypoxia, and managing the delivery devices. You need to have all possible delivery devices available in your departments where you can help giving the ordered or required oxygen therapy to the patient and assessing again the patient for managing the respiratory stability of the patient.
Colonel Sharma, could you move on? Because we have
moving on, I just have 2-3 more slides. Continuous monitoring and assessment where vital signs, skin changes, urinary output, fluids, pain assessment, lab test, reassessing again and again repeatedly if a patient is moving from sepsis to septic shock. And vasopressors, we heard about the vasopressor. The nursing contribution here is managing the flow, the infusion, monitoring the parameters when the vasopressors are on, and invasive monitoring. It's a collaborative care where initiation of the sepsis screening, orders, antibiotics, the blood culture first, antibiotics, establishing and maintaining all, and accurately reporting and managing the patient's worsening condition is part of collaborative care. And in conclusion, I would say that nurse's role is highly crucial, multifaceted, and critical for timely and effective care. Their dedication and expertise play a very vital role, and their contributions are instrumental in delivering timely and effective care. Thank you for having me over.
Thank you, Colonel Sharma. We'll come back to you in our panel discussion if we have some more time, if the organizers allow us more. I wish to thank you for your talk. Very enlightening. Well, let us see if we can come back to you. So can you stop?
Sure.
And we have Dr. Nambi back with us with a different platform, probably with a different connection. I hope he's able to sustain now for the. Can you continue, Dr. Nambi?
Yeah, I should be able to do. I'll share my screen.
Go ahead. Please go ahead. Yes, go ahead.
Probably I was cut off
here somewhere. Yes, go ahead.
And this is with respect to the etiology of community-acquired meningitis in our ICUs. And if we have done this study probably 10 years ago, we would not have pneumococcus as the #1 cause for fever with altered sensorium in an Indian ICU. Thanks to the multiplex PCR panel, the BioFire platform that we use for the meningitis panel in our centers. And this is a definite value addition. And with fever with altered sensorium, in addition to the tropical infections like scrub typhus, chikungunya, dengue, tuberculosis, cryptococcus, we do have viruses, and pneumococcus is very important cause for acute meningitis in our country. And if not for the panel, we would have not had the etiology pickup and then probably appropriate directed therapy for a proper duration, especially with pneumococcal meningitis. We would require minimum 2 weeks of IV antibiotics. And this has been already been discussed. One simple point is the volume of blood cultures that we send is crucial. It determines the yield that we're going to have out of the blood cultures. And at times, certain centers have this routine practice of not sending anaerobic blood culture. Instead, they would do 2 aerobic blood culture. Is that a right practice? Definitely may not be the right one in an Indian ICU. As seen in this study with Enterobacteriaceae, the blood culture flag was much earlier with anaerobic bottle, whereas with gram-positive organisms, the flag happened much common in the aerobic bottle first. So it does has its own value, the anaerobic bottle, the routine blood culture algorithm that we have had. 1 in 7 patients did have a flag only in the anaerobic bottle, whereas the aerobic bottle had not picked up any organism. And in that 1 in 7 patients, almost 2/3 were not obligate anaerobes. So the anaerobic bottle is not restricted to picking up only obligate anaerobes. It does has its role with other organisms, let it be the gram-negatives and the Streptococcus species too. We have to keep that in mind. And I would just present one case which gives you a real life example of how we integrate clinical information and then rapid diagnostics to the patient care. This is a patient with left lower limb complicated skin and soft tissue infection presenting with sepsis, septic shock, multi-organ dysfunction. The blood culture is growing gram-positive cocci. With that, you would be expecting either Streptococcus pyogenes or Staph aureus. And he was sick. He was in the ICU. So we did run the blood culture identification panel. This was in the year 2016. So we had the BCID1 at that time, BCID1. And in a span of 1 hour, after the blood culture flag, we had the organism identified as Staphylococcus aureus, and the MECA gene is not detected. And it means that we had the etiological diagnosis of methicillin-sensitive Staph aureus causing complicated skin and soft tissue infection in a span of 24 hours, in a span of 60 minutes from the time the blood culture flags. And this patient was on vancomycin meropenem. With this information, we could start IV flucloxacillin. Another day, we could stop the vancomycin meropenem. So the traditional testing, if you not have MALDI in your center, would take at least 48 to 72 hours. With MALDI, perhaps it is a little less, but still, it is a very valuable tool in your ICU dealing with septic patients. And another test which made us understand the value of molecular diagnostics is the expert CABA-R. When we tried doing the expert CABA-R with gram-negative isolates, bacteremic isolates in our hospital, what we found was 50% of the isolates carried OXA in our system. 1/3 had NDM. Now 15% had both NDM and OXA. This was done during the period from 2015 to 18. At that time, all we thought was the carbapenem resistant gram-negative resistance in India is mediated by NDM. But this epidemiological study made us realize that more than NDM, we did have OXA among us. And with OXA production, there are enormous therapeutic implications in this day and age. And this is a sick patient with cholangitis and gram-negative bacteremia. This is a patient who underwent ERCP. The next day, patient goes in for a septic shock, multi-organ dysfunction. The blood culture flags gram-negative. And right now we have the BCID2 in our system. When we tried running it, what we could pick up was it was Klebsiella pneumoniae, and the resistance genes picked up was CTXM, ESBLs, and then OXA48-like. And this is real-time information. Otherwise, even with the MALDI ID, you'll have to wait for a day before you could tailor down therapy. This patient was initially started only on meropenem. With this information, we could upgrade the therapy to ceftazidime avibactam, and he did well. Just because we could integrate the rapid molecular diagnostics into our treatment algorithm, and communication with the labs is very crucial in these kind of sick patients when you have blood culture flagging gram-negatives. And there is one small study done in an Indian ICU with KIMS Hospital in Trivandrum, which was published in IJCCM, looking into the BCID, very small study, around 25 patients. What they found was the concordance between the phenotypic and the genotypic in terms of organism identification was 100%. The antibiotic susceptibility testing was also 100%, but this is very small numbers. And they had Klebsiella pneumoniae as the commonest organism in their ICUs, and OXA48 was the predominant mechanism. BISID works for carbapenemases, works well for E. coli and Klebsiella. As Dr. Balaji already pointed out, it may not be the perfect answer for Acinetobacter and Pseudomonas, but with respect to organism identification, it definitely helps with respect to Acinetobacter and Pseudomonas, whereas with the resistance mechanism, since we have other mechanisms of resistance, it may not be that useful for Pseudomonas and Acinetobacter. This is our experience in our center, which will be published shortly, probably in a month. It is already accepted for publication. Again, looking into the utility of blood culture identification too, into the ICU gram-negative bacteremic flags. The sample size was around 200. The concordance between the traditional culture phenotypic and the BISIT was around 99% with respect to the organism identification. With respect to the drug susceptibility testing, what is the match between the genotype and phenotype? It was around 96.5%. The antibiotics were tailored in almost 82.5% of these patients based upon the information that we have out of this BISIT. And polymyxin-based therapy was avoided in almost 70% of these patients just because we had an information saying that it was not harboring any carbapenem resistant genes with E. coli Klebsiella, or at times with an OXA producing agent, we would have used ceftazidime avibactam and helped in. And this kind of information helps us in avoiding polymyxin, which has its own list of toxicities. And this is the information that we have in that study. And with respect to the organism identified and with respect to the enzymes, carbapenemases or the CTXMs that are picked up. But we need to remember that blood culture identification 2 panel may not be the complete answer for all gram-negative flags in our ICU, because it does not pick up the Burkholderia species. It does not pick up some vague non-fermenters like Elizabeth Kingae. It does not pick up Salmonella paratyphi. Does not pick up Morganella. It does not pick up Aeromonas. So we need to keep that in mind when we use this test in our ICU. It has value when it identifies the organism. It has value when it picks up the resistant genes, more so with respect to Enterobacteriaceae. The resistance genes pickup is of less value with non-fermenting gram-negatives. So this may not be the complete answer, but definitely a value addition whenever we deal with E. coli Klebsiella in our ICUs. Another alternate system, which is FDA approved, but I'm not sure whether it is available in India. It is available in the US, which is the Accelerate Phenotype System, which is in slight modification to what we have with the blood culture identification system, because it helps us giving the antibiotic susceptibility testing also. So you need to have the blood culture flag, and from the blood culture flag to organism identification, from the blood culture flag to the susceptibility testing, blood culture flag to the antibiotic therapy. When they tried doing the study in an US ICU, they found that when they had used this Accelerate Pheno system, it definitely reduced the time with respect to identification, with respect to giving appropriate therapy. The blood culture identification system of the BioFire panel, it picks up resistance, but does not tell what works. Whereas with this system, this is a rapid antibiotic susceptibility testing, just similar to Vitek reveal what Dr. Balaji pointed out. It helps us in telling us what would work. So that way it would be of more value, but there is a time interval of around 8 hours from the time of blood culture flag before we could have this information. With respect to gram-negative therapy, what are the current options in India with ESBLs, carbapenems or the drugs, BLBLIs like cefpoarizone, sulbactam or piptaz are one step less. Empiric carbapenem resistant gram-negative cover, we'll have to use polymyxins plus or minus other agents. With definitive therapy, polymyxins are expected to work uniformly across E. coli, Klebsiella, Acinetobacter, Pseudomonas, carbapenem resistant strain, but they have their own share of toxicities, let it be the kidneys and the nerves. Ceftazidime avibactam is a value addition, especially if you're dealing with an OXA producer, and probably when the synergy is positive with the NDM production, you could use in combination with ceftazidime avibactam plus astrium. As far as the Acinetobacter and Pseudomonas, still we have to rely upon polymyxins plus or minus in combination with other agents. That is where we stand. And the newer drugs that are expected to come into the Indian market, ceftolozane tazobactam may not come. Ceftazidime avibactam that is already available. Ceftolozane tazobactam is useful for Pseudomonas. Meropenem, Vaebactam, Imipenem, Relibactam will not be useful in the Indian setup. Two drugs that may be available in this year. One is cefiderocol, other one is plazomicin. Cefiderocol on paper looks good. It takes care of E. coli, Klebsiella, Acinetobacter, Pseudomonas, but already resistance to cefiderocol has been described in the US. Plazomicin, it is another value addition to the existing armamentarium, but may not be the complete answer to the resistant gram negatives in Indian ICU. Phage therapy is maybe a future direction. When you look into non-antimicrobial way of handling AMR, one future is phage therapy or phage therapy. This is one such glorious example of an ICU patient who was stuck up in the ICU for almost 8 months. He had a persistent carbapenem, extreme drug-resistant Acinetobacter in his bloodstream, and with a phage cocktail, they could clear up the Acinetobacter, and this man could live longer to write a book called The Perfect Predator, highlighting the phage therapy as a novel therapy. There are occasional case reports, but still it is not standardized. Perhaps future we may have this as an important therapeutic option in the management of drug-resistant pathogens. And this is an era of chat GPTs and all those things. Perhaps as time progresses, we would have machine learning algorithms and artificial intelligence would be utilized in clinical decision support and sepsis. As of now, I don't see that happening in Indian ICUs, but I think future lies in the use of AI in the management of sepsis. But I believe strongly that hospital infection control will be the biggest factor with respect to prevention of sepsis in our Indian ICU. It's not important that we choose the right drug for your Acinetobacter, Pseudomonas, or even Candida auris, but if we can make an effort to prevent the spread of these organisms within the ICUs, that is the best thing that we could do. Horizontal infection control measures like having bundles to prevent hospital-acquired infections, antimicrobial stewardship, focus on environmental cleaning, disinfection, looking into novel methods like UV radiation, all those things, time, health, hand hygiene, education awareness. I think the future lies with hospital infection control. And if that is one area where you could have novel methods coming up in the near future. And I think we are in a time where you have the traditional systems like the Gram-Stein, the routine culture, susceptibility testing, but at the same time, you have the newer methods like rapid molecular diagnostics, all those things. This is an exciting time to be a microbiologist or an infectious disease physician, because we have new tools to make rapid diagnosis and probably new drugs or new therapeutic models to take care of our patients. But we should strike a balance between the tradition and the modern, and we should embrace the modern techniques, and we should kind of incorporate into the tradition so that patients get benefited. And that's my last slide. With respect to antimicrobial resistance, when you have a pathogen infection and then infection triggers antimicrobial use, and whenever there is antimicrobial is there, then you'll have antimicrobial resistance. As a result, you and I face antimicrobial resistant pathogens. So how do we tackle this? It has to be multimodal. We have to prevent infection. Hospital infection control, you need to focus on the community level, food, sanitation, water, clean air, vaccination. That is how you prevent infection. And then effective diagnosis and treatment, diagnostic stewardship, all those things are very important. Optimize the use of antibiotics. Antimicrobial stewardship is key. And then prevent transmission of these organisms in the ICU. Again, focus on hospital infection control. And that would probably, when you deal with this problem at multiple levels, you could kind of take over this antimicrobial resistance. Thank you. And that's my last slide. I apologize that I couldn't join in earlier with I had some connectivity issues. Thank you.
Thanks, Dr. Nabi, thanks a lot. You can stop sharing, yes. I do not know, we are done with the session that we had the commitment for. Now the issue is with the sponsors as to do we have some time. We are having huge number of questions. It's hard to keep pace with that, but we could, if you want, we could take a few questions if there is some time. That can be, we are already past 4:30. So is the organizers ready to give?
Yes. Certainly, sir. We could take up certain questions, and those which won't be answered right away, we'll be replying to them, to the participants. We'll be
What time you give?
generating.
What time you give?
Sir, you could take up certain pertinent questions which you feel can be taken up right away by the panel.
Yeah, that's fine. So you give us 5 minutes or so, or what?
15 minutes.
So you could take 10, 15, whatever is convenient to you. That's okay.
So we can take around 10 minutes or so.
Yes, sir.
Because the holding time for any individual is not more than 45 minutes by and large. So we already held them much beyond that time. And it was really a wonderful marathon session with varied questions getting answered, and with a wonderful session that we started with Dr. Todi, and he really gave an answer as to what is the resource limitation. Beautifully explained, sir, that resource limitations are at various levels. It doesn't always extrapolate to having the enough dough in your pocket. It is when you have things and you don't do it, it's still again a low resource. So it is a low resource on the niyat, what we say, that you have to have the niyat to do it. So it is very beautifully explained as to how you can do a lot many things in controlling or diagnosing sepsis. You need to add anything further, because there are people who are talking, is Q so far still relevant?
Yeah.
As the setting.
I have selected 2 or 3 questions from the chat box. If you
Please go ahead, sir.
Yeah, the first one was the QSOFA as a screening tool. You know, in the previous iteration, QSOFA is taken as a screening tool. Now it has been withdrawn because it is more of a prognostic marker rather than a screening tool, because this is applicable even to a non-septic patients. So QSOFA is not used for screening. The second was the type of fluids which needs to be given. The previous sepsis, surviving sepsis, said that balanced fluid, which has got low sodium, low chloride, but the recent 2 trials have said that balanced fluid is as good as normal saline. So probably the newer surviving sepsis will take it off, and we don't have to give balanced fluids, which are a little more costlier than normal saline. Third one was the early use of...
mostly, is it the crystallites that are much better than the fluids plain?
Crystalloids are definitely better than colloids. Colloids are out, but within crystalloid, whether we should be giving normal saline or we should be giving this newer balanced solution, which have got low sodium and low chloride, because hyperchloremia was found to be bad for septic patients in 2 very big studies published in NEJM. But the recent 2 studies from Australia and Brazil have shown that balanced is as good as normal saline. So hopefully one doesn't have to go for balanced solution. One can go for just normal saline for fluid resuscitation. The other one was the early use of vasopressor. Till now, the paradigm was you give fluids. If patient is not responding to fluids by increasing pressure, then you add a vasopressor. But now the importance of correcting hypotension at a very early stage has become very important. So the paradigm now is to start vasopressor almost along with fluid in severely hypotensive patient. So that is what has been a little change. You don't wait for giving 20, 30 cc of fluid per kg and then start vasopressor. You can start vasopressor at the same time. So these 3 were the main things on sepsis I thought I would take out from the chat.
Thank you very much. Thank you very much. Dr. Balaji, are you around?
Around.
Oh, yes. So people are wondering, as CDC is trying to tell us, it's just within 1 hour is enough that you collect the samples or then give the antibiotics. So you have given them the classification of 1 hour and 3 hours. So they were wondering, are they going to, is there a variation with the CDC guideline than what we were talking about as far as...
Yes. So definitely the earlier suggestion of within 1 hour antibiotic has increased inappropriate antibiotic in close to 40% of the not indicated situation, they have to prescribe antibiotics. So to cut down on those misuse and overuse of antibiotic, they have extended the time to 3 hours so that they can have a rethink and they can rule out non-infectious disease.
Very
So,
right.
and they can start the antibiotic.
That's very right. That's very well taken. And some other people also are talking about the adequacy of the volume. They think it's an impossible thing that we are not going to have the adequate field anytime. So, but I think we need to discuss that and convince ourselves and the users that that's not science. Dr. Balaji.
Yes, sir. Most important is, unfortunately, most of the blood collection tray, they do keep only 10 ml syringe. If you keep 10 ml syringe, you cannot draw beyond the 8 ml. Many people, to be on the safer side, they stop at 8 ml.
Very true.
So if you keep a 20 ml syringe or 40, 50 ml syringe, it looks heavy and little scary, but that is the best way to do. So easily you can draw more blood and it can be inoculated into the blood culture bottle. If you look at in my slides, I have shown on an average 2 to 5 ml only they are adding, where you are supposed to add 10 ml.
Very true. Since we have got those automated systems that clearly tells us many times as to what is the field, and you yourself understand that what you said was perfectly right. It's not more than 7 ml, and in children not more than 0.5 to 1 ml. So that is how they are actually getting into the field, and the possibility of having blood culture positives is really, really less. And that's why they are talking of blood culture negative sepsis. So more often it is the iatrogenic part of it that not taking the proper field. But there are reasons for culture negative sepsis. Dr. Nambi, could you take that on? Culture negative sepsis.
Yeah, when we rely upon blood cultures for a diagnosis of sepsis, probably in two situations, it may not help us much. One is pneumonias. When you have a proper bacterial pneumonia, the chance that the blood culture is going to pick up is not more than 20%. And so would be meningitis also, with acute bacterial meningitis. And then skin and soft tissue infections landing in ICU also, the blood culture yield is going to be less. So these are three select situations where compared to a pyelonephritis or an intra-abdominal infection, where good volume blood cultures are good enough, whereas with a community-acquired pneumonia landing in an ICU or a community-acquired bacterial meningitis or a skin and soft tissue infections, these are three select situations. In spite of having bacterial infection, in spite of having sepsis, we may not have blood cultures picking up. But if that same pneumonia guy gets intubated, ventilated, it helps in making up some respiratory cultures. And again, with skin and soft tissue infection, we need to send tissue for cultures. So that is very important. No point doing wound swabs. And these are the three select situations that I could think. More so with pneumonia and meningitis. Yeah.
Even in bacterial endocarditis, if they are afraid to collect the right kind of samples and have those 6 sets, they are not likely to get on to the diagnosis of bacterial endocarditis. And unfortunately, that's the only way to actually diagnose bacterial endocarditis. That is one of the areas. Dr. Todi, if you are still there. Yeah, people are asking of biomarkers. They must be wondering as to why have we skipped biomarkers in the diagnosis, because it's a very popular topic when anytime sepsis is discussed. So biomarkers cannot vanish from discussion. So as usual, procalcitonin and things like that.
When you go through the guidelines and the literature for diagnostic purpose, it is not recommended. But it has become a very common practice for us to do these biomarkers. They are good for prognosis and probably de-escalation of antibiotic. But based on a procal level, I should not say whether the patient is septic or not, or whether he has an infection or not. And so there was a big study done in NEJM for COPD exacerbation. If one go by procalcitonin and not give antibiotic for a normal procalcitonin, the mortality was high in acute exacerbation of COPD. So I think it is the clinical. One has to see as a whole and see whether the patient is infected or not.
Absolutely. And I think even IL-6 and IL-10 also will also go a similar way when you are trying to talk of giving some kind of a association with sepsis when you are doing these kind of assays. So these are not really high on cards when we are talking of diagnosing sepsis. The another area people are asking is about the fungal sepsis. Have we missed on the fungal sepsis? Is there something different that we need to do in fungal sepsis? Dr. Todi first and Dr. Balaji, if you can add on to the diagnosis.
In our country, it's a big dilemma that patient not responding to broad spectrum antibiotic who's at risk of candidemia, can he have fungal sepsis? Now, what is
it out also? You put them on broad spectrum kind of things, and you find that the candida is there now.
Yeah, you see, in the West, somebody not responding to meropenem, the chance of fungemia becomes high. But in our country, not responding to meropenem could be Acinetobacter, not necessarily fungemia. And that becomes a big problem. So that's why probably beta-D-glucan and other biomarkers may become important, and having colonization with candida in a very high-risk patient becomes important to have some kind of an idea whether the patient can be having a fungal sepsis. So it's difficult to differentiate candidemia from fungemia and to start empirical antifungal.
Because very often these patients are on a catheter as well. So whether these are colonizers or they are really having cystitis or not because of candida or yeast infections, because there have been studies where you say that you ignore cystitis due to candida or yeast, the mortality may go up. So there is
the markers of chance of having candidemia, but given one individual case, it becomes so difficult because the risk factor for bacteria and candidemia are the same.
Yes. Dr. Balaji, anything on diagnosis?
Whatever Dr. Todi has told, sir.
Dr. Nambi, what your experience on this candida business?
In a hospitalized patient, when we think there is a new infection episode or a sepsis episode, for which I don't have positive bacterial cultures, neither I have a focus of infection clinically, let it be a UTI, intra-abdominal, or I'm suspecting a bloodstream, or there is a pneumonia, ventilator-associated pneumonia. So when I'm not able to have a bacterial pathogen identified, and I don't have a clear focus of infection based on my clinical decision making, but I think my hospitalized patient has got some new septic event. So that is when I'll have to think of invasive candidiasis. So when these patients are colonized or have some respiratory or urinary cultures growing, or when they have beta-D-glucan, which is high. So in those situations, it really helps. Because even when you clinically suspect invasive candidiasis, chance that the blood culture is going to pick up candida in the blood is 50 to 70% the max. There is always 1 in 2 who may have invasive candidiasis, but the blood culture is not picking up. In that situation, we'll have to go by the clinical call. Culture negative sepsis in a hospitalized patient where there is no organism, neither a source identified, we will have to and we think infection is a possibility. In that situation, candida has to be considered.
Yeah. Dr. Balaji, people are miffed by two things. When you told them that you do NAT on whole blood directly and try and pick up the sepsis.
Yes, sir.
And they are miffed by that as to how good, how bad is that. And another gentleman is asking, do you see MAXI-MRSA?
MAXI-MRSA, first I will answer the second question. MAXI-MRSA in humans in India, we have not seen. Majority of the MAXI comes from the pork pig forms. Mainly, even within Europe, the Scandinavian countries alone has got MAXI. So beyond that, MAXI is not much commonly seen. However, the 4th generation Cepheid expert picks up that MAXI also. No other commercially available system has got, I think few has got recently the MAXI in addition to MECA. That is about the MAXI, but not seen in the humans as of now, much in India. It's mainly MECA. Second question is, first question was
that with the whole blood.
Whole blood. So now, the FDA approved kit system platform is there in US. T2 bacteria, T2 candida, and the T2 gram-negative resistant gene. So these three systems say about within 1 hour, it gives the organism identity from the direct blood and as well as the AMR. So it's very expensive. It's outside America. I don't think that it's available. However, recently, many number of companies, at least I know 10 companies within India and outside, they are developing kits, and it's for validation. I'm hoping in another 1 or 2 years, more number of successful kits closer to FDA approval, it will be available.
Thank you, Dr. Balaji. Colonel Sharma, can you help in the blood culture business, because you are the first contact when we have the issue of blood culture. You very beautifully explained how to do that and how to collect samples, and then but you also do understand the difficulties and the inhibitions that are being faced.
So let me just put it across. Nurses are completely responsible for managing the blood cultures. I just heard that on the 10 ml syringe thing. So there is a blood collection tray in all the ICUs, in the wards, as well as in the HDUs. We should have the right number of right size of syringes and multiple syringes, so that nurses do not tend to draw blood culture with a 2 ml or a 5 ml syringe. They use appropriate syringe. They always have the blood culture bottles, aerobic and anaerobic both. And they also need to understand that usually a single culture is not to be taken, or drawing a culture from a already flowing IV line is just not going to add any value, or not sending a contaminated culture. It's only going to waste time of the clinicians for crucial patient management. All of this has to be part of a nursing SOP and nursing infrastructure in all the areas in the hospital.
Thank you, Colonel Sharma. I think we had a very useful session, and we are already exceeded by almost half an hour. So thanks for people who have been here. Dr. Todi, he's a very busy person, so he was first to run away. So I will also, that's a hint that we need to wind up and not extend this session any further. And I hand it over back to the organizers. Devyani, you can take over. And I am very grateful for all the faculty who were here and participated in a very valuable discussion on sepsis.
Thank you. Thank you, Dr. Vatal.
Thank you so much, sir. I would like to extend my sincerest gratitude to all the esteemed panelists, Dr. Todi, Dr. Balaji, Dr. Nambi, Colonel Binu, and our honorable moderator, Dr. Chandvatal, for giving us a snapshot of sepsis, the magnitude of the matter on hand, and the know-how of diagnostics and management. Before concluding, let us take a flashback of the last 110 minutes with a quick quiz and reinforce certain key takeaways from this event. Here we go. Could we have the polls, please?
I'm sorry we might have disappointed some of the people who asked some questions, but due to paucity of time, we could not.
We would be replying to all the queries, and certainly all the queries would be prioritized and we'll be answering them.
They spent their valuable time.
Yeah, absolutely. So we have the question on screen, that is, sepsis is the #1 cause of option A, death in hospital, option B, hospital readmissions, option C, is it healthcare cost, or option D, all the above. We have 10 minutes on hand. 10 seconds on hand. We are good to go. So we have the answer here. 85% of the people have answered correctly. It's actually all the above. Sepsis is a huge burden, and it has an impact on all of these. Next question, please. Flashing on your screen. Yes.
Did we have the poll before?
No, this is the concluding parts. Yeah. So as per the Surviving Sepsis campaign, what consists of the first are bundle, Is it measuring lactate level only? Is it measuring, is it obtaining blood culture before administration of antibiotics? Broad spectrum antibiotic coverage? Is it option D, initiating rapid crystalloids? Option E, applying vasopressors? And option F, is it all of the above? So the poll is finished. 65% have answered correctly. It's actually all the above. That was explained wonderfully by Dr. Todi. Could we have the next question, please? Flashing on your screen in a few seconds. The advantage of paired blood culture are: 1, incremental yield. Option B, it helps you differentiate between skin flora and pathogen. Option C, overall it has an impact on cost saving, antibiotics and length of stay. Or is it option D, all of the above? 10 seconds remaining, fastest fingers first. Good to go. We have the result. We have 81% of people who have answered correctly. It has an impact on all of the above and it has a huge advantage. It has an edge, definitely. Next question, please. Question number 4 going live in a few seconds. BioFire film array BCID2 panel has how many targets? Is it 12? Option B, is it 18? Option C, is it 32? Option D, is it 43? Your answers, please. All right, we have 41% who have answered correctly. It's 43, it's the maximum on the list, 43 targets by the BCID2 panel. And we go for the next and the last question. That's question number 5. Can we have it on screen? So finally, the question is for adults with an initial diagnosis of sepsis or septic shock and adequate source control where optimal duration of therapy is unclear. The Surviving Sepsis campaign suggests using procalcitonin and clinical evaluation to decide when to de-escalate. Is it true or is it false? Good to go. 91% have correctly answered. So it is true. The point number 31 of Surviving Sepsis Campaign Guideline categorically states this. So with this, thank you for your response. And when it comes to sepsis, remember it is all about time. On that note, on behalf of bioMeru India, I would like to extend a hearty vote of thanks to Indian Association of Medical Microbiology, to all our panelists and our moderator for gracing their important work and sharing with us their valuable insights, and for that deep diving into sepsis. I must mention our deep sense of appreciation for the audience and the participants for investing their time in the mission that binds us all. Say sepsis, save lives, spread the word. Before we log out, we would love to hear from you. Your feedback counts. Kindly fill in the feedback form that would be flashing on your screen right away. Thank you so much. It has been an absolute pleasure.